Special tests of all joints. Special tests for hip joint. Thomas test. Aim of the test: identifies tightness of hip flexors. Patient position: patient is supine and one hip and knee are maximally flexed to the chest and held there. Opposite limb is kept straight on table. Observe if hip flexion occurs on straight leg as opposite limb is flexed. Positive sign: positive if straight limbs hip flexes and are unable to remain flat on the table. If knee is straight, indicates tightness of rectus femoris. Ober's test. Aim of the test: identifies tightness of tensor fasciae latae and or iliotibial band. Patient position: patient lies on the side with lower limb flexed at hip and knee, passively extended and abduct, testing hip with knee flexed to 90 degrees. Slowly lower uppermost limb and observe if it reaches the table. Positive sign: positive if uppermost limb is unable to come to rest on the table. Elite test. Aim of the test: identify tightness of rectus femoris. Patient position: patient prone and knee of testing limb is flexed. Observe the hip of testing limb. Positive sign: positive if hip of the testing limb flexes. 90-90 hamstring test. Aim of the test: identifies tightness of hamstring. Patient position: patient supine and hip and knee of testing limb is supported in 90-degree flexion. Passively extend knee of testing limb. Positive sign: positive if knee is unable to reach full extension. Piriformis test. Aim of the test: identifies tightness of the piriformis muscle, piriformis syndrome. Patient position: patient is supine and foot of tested leg is placed lateral to the opposite limb's knee. Testing hip is adducted. Observe the position of testing knee relative to the opposite knee. Positive sign: positive if testing knee is unable to pass over resting knee and or reproduction of pain in buttock and or along sciatic nerve distribution. Patrick or Faber test. Flexion, abduction, external rotation. Aim of the test: identify dysfunction of hip and sacroiliac joints such as mobility restriction. Patient position: patient lies supine, passively flex, abduct and externally rotate tested leg so that foot is resting above the opposite knee. Slowly testing leg down towards the table surface. Positive sign: positive test when involved knee is unable to assume relaxed position and or reproduction of painful symptoms. Standing flexion test. Aim of the test: identify dysfunction of sacroiliac joint. Patient position: patient stands with his feet apart. Therapist stands behind him with his thumbs placing on the posterior superior iliac spine, PSIS. Ask the patient to flex forward as much as he can. Therapist observes both PSIS. Normally both equally move. Positive sign: positive when one PSIS move further cranially than the other, which is the affected side. Standing flexion test. Aim of the test: identify dysfunction of sacroiliac joint. Patient position: patient is sitting with arms across the chest. Therapist stands behind him with his thumbs placing on PSIS. Ask the patient to flex forward and passes elbows between the knees as if to touch the floor. Positive sign: positive when PSIs move further cranially than the other, which is the affected side. Long sitting test. Aim of the test: identify anteriorly or posteriorly rotated innominate based on apparent leg length differences. Patient position: patient is supine, both hips and knees extend. Therapist standing with thumbs on patient's medial malleoli relative to each other. Patient slowly assumes the long sitting position and malleolar position is reassessed. Positive sign: when leg appears longer in supine but shorter in long sitting, this indicates anterior innominate rotation on affected side. Opposite is for posterior innominate rotation. Trendelenburg sign. Aim of the test: identifies weakness of gluteus medius or unstable hip. Patient position: patient standing and asked to stand on one leg. Flex the opposite knee. Observe the pelvis on the stance leg. Positive sign: positive when contralateral pelvis drops when lower limb support is removed. Leg length test. Aim of the test: identifies true leg length discrepancy. Patient position: patient supine and pelvis is balanced, aligned with lower limbs and trunk. Measure distance from ASIs to medial malleolus on each limb several times for consistency and compare results. Positive sign: a difference in length between two limbs is noted, identifying a true leg length discrepancy. This test will determine if the limb discrepancy is true or functional. True discrepancy is caused by an anatomical difference in bone lengths, either tibia or femur. Functional discrepancies are not anatomical in origin and are the result of compensation due to abnormal position or posture such as pronation of foot or pelvic obliquity. Special tests for knee joint. Collateral ligament instability test. Valgus and varus test. Aim of the test: identifies collateral ligaments laxity. Patient position: patient is supine. The entire lower extremity is supported and knee placed in 20 to 30 degree of flexion. Valgus force placed through knee to test medial collateral ligament. Varus force placed through knee to test lateral collateral ligament. Positive sign: primary finding is laxity, but pain may be noted. Lashman stress test. Aim of the test: indicates integrity of anterior or posterior cruciate ligament, ACL or PCL. Patient position: patient supine with testing knee flexed 20 to 30 degree. Stabilize femur and passively try to glide tibia anterior, posterior. Positive sign: finding is excessive anterior posterior glide of tibia. Anterior drawer test. A of the test indicates integrity of anterior cruciate ligament. Patient position: patient supine and testing hip flexed to 45 degree and knee flexed to 90 degree. Passively glide tibia anteriorly, posteriorly following the joint plane. Positive sign: positive finding is excessive anterior glide. Muck-Murray test. Aim of the test: identifies meniscal tears. Patient position: patient supine with testing knee is in maximal flexion. Passively internally rotate and extend the knee. This tests lateral meniscus. Test the medial meniscus with the same procedure except rotate the tibia into lateral rotation. Positive sign: positive finding is reproduction of click and or pain in the knee joint. Apley's test. Aim of the test: helps to differentiate between meniscal tears and ligamentous lesions. Patient position: patient prone with testing knee flexed to 90 degrees. Stabilize patient's thigh to table with your knee. Passively distract the knee joint, then slowly rotate tibia internally and externally. Next step is to apply a compressive load to knee joint and once again slowly rotate tibia internally and externally. Positive sign: pain or decreased motion during compression indicates a meniscal dysfunction. If pain or decreased motion occurs during the distraction, then it is most likely a ligamentous dysfunction. Clark's sign: aim of the test indicates patellofemoral dysfunction. Patient position: patient supine with knee in extension resting on table. Push posterior on superior pole of patella, then ask patient to perform active contraction of the quadricep muscle. Positive sign: pain is produced in knee as a result of the test. Patella tap test, ballotable patella. Aim of the test indicates infrapatellar effusion. Patient position: patient supine with knee in extension resting on table. Apply a soft tap over the central patella. Positive finding is perception of patella floating, dancing patella sign. Patellar apprehension test. Aim of the test indicate past history of patellar dislocation. Patient position: patient supine and patella is passively glided laterally. Positive sign: patient does not allow and or doesn't like patella to move in lateral direction to stimulate subluxation or dislocation. Special tests of the ankle and foot joint. Anterior drawer test. Aim of the test identifies ligament instability, particularly anterior talofibular ligament. Patient position: patient is supine with heel just off edge of table in 20-degree plantar flexion. Stabilize lower leg and grasp foot. Pull foot talus anterior. Positive sign: positive finding if foot talus has excessive anterior glide and or pain is noted. Talar tilt Kliger. Aim of the test identifies ligament instability, particularly calcaneofibular ligament. Patient position: patient side lying with knee slightly flexed and ankle in neutral. Move foot into adduction, testing calcaneofibular ligament, and into abduction, testing deltoid ligament. Positive sign: positive finding if excessive adduction or abduction occurs and or pain is noted. Thompson test. Aim of the test: evaluate the integrity of Achilles tendon. Patient position: patient prone with foot off the edge of table. The examiner squeezes the calf muscles. Normally there is plantar flexion. Positive sign: no movement of foot while squeezing calf indicates positive finding. Homan's test. Aim of the test: test for deep vein thrombosis, DVT. Patient position: patient supine or sitting with knee flexed. The examiner forcibly dorsiflex the patient's ankle, then palpate the calf muscle. Pain in calf is a positive sign and should be referred. Squeeze test. Aim of the test: identify integrity of the syndesmotic ligaments. Patient position: patient supine or sitting with knee flexed. The examiner places his hand 6 to 8 inches below the knee and squeezes the tibia and fibula together. Positive sign: positive test results in pain in the ankle, which indicates injury of the syndesmotic ligament and a possible high ankle sprain. Fees line. Aim of the test: identify the position of the navicular, the keystone of the medial longitudinal arch. Patient position: while the patient is NWB, mark inner apex of the medial malleolus and plantar aspect of first metatarsophalangeal joint. Have the patient stand 8 to 15 cm apart. Palpate the navicular tuberosity, noting where it is in line to the other two landmarks. Positive sign: navicular drops more than 10 mm indicates pes planus, flat foot. Special tests of the lumbar spine. Straight leg raising, SLR or Lassig's test. Aim of the test: identifies dysfunction of neurologic structures that supply lower limb and also indicates the unilateral dysfunction of the sacroiliac joint. Patient position: patient is supine with legs resting on table. Passively flex hip of one leg with knee extended until patient complains of shooting pain into lower limb. Slowly lower limb until pain subsides, then passively dorsiflex foot. Positive sign: positive finding is reproduction of pathological neurologic symptom when foot is dorsiflexed. More illustration of SLR test. ROM can demonstrate problems in different areas. 0 to 30 degree equals hip pathology or severely inflamed nerve root. 30 to 50 degree indicates sciatic nerve involvement. 50 to 70 degree is probable hamstring involvement. 70 to 90 degree when sacroiliac joint is stressed. Neural tension and mobilization for lower quadrant by SLR. While patient is supine, several variations may be done: ankle dorsiflexion, ankle plantar flexion with inversion, hip adduction, hip medial rotation, and passive neck flexion. The maneuver may also be performed long sitting, slump sitting position, and side lying. These various positions of the lower extremity and neck are used to differentiate tight or strained hamstring from possible sites of restriction of nerve mobility in the lumbosacral plexus and sciatic nerve. Once the position that places tension on the involved neurological tissue is found, maintain the stretch position and then move one of the joints a few degrees in and out of the stretch position, such as ankle plantar flexion and dorsiflexion of knee. Knee flexion and extension. Ankle dorsiflexion with eversion places more tension on the tibial tract. Ankle dorsiflexion with inversion places tension on the sural nerve. Ankle plantar flexion with inversion places tension on the common peroneal tract. Adduction of the hip while doing SLR places further tension on the nervous system because the sciatic nerve is lateral to the ischial tuberosity. Medial rotation of the hip while doing SLR also increases tension on the sciatic nerve. Passive neck flexion while doing SLR pulls the spinal cord cranially and places the entire nerve system on a stretch. This technique is called SLR modification test. Well leg or crossed SLR test. Aim of the test: same as for SLR test. Patient position: patient is supine and raised the unaffected leg. Positive sign: positive finding is pain on the back of the affected leg, the one on the table. Tension sign for sciatic nerve. Aim of the test: identifies sciatic nerve irritation. Patient position: patient is supine with flexed hip and knee 90 degree. The examiner grasps the heel with one hand and the other grasps the thigh. Knee is then extended as far as possible with the examiner palpating the tibial portion of the sciatic nerve as it passes behind popliteal space. Positive finding: tenderness and reproduction of sciatic symptoms. Bowstrings test, cram test. Aim of the test: indicates sciatic nerve tension. Patient position: patient supine with passive SLR on involved side. If pain radiating, the examiner flexes the subject's knee to approximately 20 degree in attempt to reduce pain. Pressure then applied to popliteal area to produce radicular pain. Positive finding: painful radicular reproduction with popliteal compression. Femoral nerve traction test. Aim of the test: identifies compression of femoral nerve anywhere along its course. Patient position: patient lies on non-painful side with trunk in neutral, head flexed slightly, and lower limbs hip and knee flexed. Passively extend hip while knee of painful limb is in extension. If no reproduction of symptoms, flex knee of painful leg. Positive sign: positive finding is neurological pain in anterior thigh. Slump test. Aim of the test: detect sciatica or dural irritation. Patient position and procedure. Begin with the patient sitting upright. Have the patient slump by flexing the neck, thorax, and low back. Apply overpressure to cervical spine. Dorsiflex the ankle and then extend the knee as much as possible to the point of tissue resistance and symptom reproduction. Release the overpressure on the spine and have the patient actively extend the neck to see if symptoms decrease. Increase and release the stretch force by moving one joint in chain a few degrees, such as knee flexion and extension or ankle dorsiflexion and plantar flexion. Positive sign. Positive finding is sciatic nerve, sciatic pain, or reproduction of other neurological symptoms. Kernig-Brudzinski sign. Aim of the test: identify nerve root pathology or dural irritation. Patient position: patient is supine and actively lifts the head, flexing the cervical spine while actively extending the leg with flexing the hip until pain is felt, then flexes the knee. Positive sign: pain disappears when they flex the knee. Quadrant test. Aim of the test: identifies compression of neural structures at the intervertebral foramen and facet dysfunction. Patient position: patient is stride standing. Examiner stands behind him, grasping the shoulders. Patient extends the spine, side bends and rotates to affected side. The examiner provides overpressure through the shoulders. Positive finding: radicular pain indicates compression of the intervertebral foramina that impinges on the lumbar nerve roots. Local pain, not radiating, indicates facet joint pathology. Symptoms isolated to the area of PSIS may indicate SI joint dysfunction. Valsalva maneuver. Aim of the test: identifies a space occupying lesion. Patient position: patient is sitting. Instruct patient to take a deep breath and hold while they bear down, as if having a bowel movement. Positive finding: increased low back pain or neurologic symptom into lower extremity. Bicycle test. Van Gelderen test. Aim of the test: differentiates between intermittent claudication and spinal stenosis. Patient position: patient is seated on stationary bicycle. Patient rides bike while sitting erect and time how long they can ride at a set pace or speed. After sufficient rest period, have patient ride bike at same speed while in a slumped position. Determination is based on length of time patient can ride bike in sitting upright versus sitting slumped. Positive findings: if pain related to spinal stenosis, should be able to ride bike longer while slumped. Stork standing test. Aim of the test: identifies spondylolisthesis. Patient position: patient standing on one leg. Cue patient in trunk extension. Repeat with opposite leg on ground. Positive sign: pain in low back with ipsilateral leg on ground. Special tests of the shoulder joint. Tests for muscles and tendons pathology. Yergason's test. Aim of the test identifies the integrity of transverse ligament and bicipital tendinitis. Patient position. Patient is sitting with shoulder in neutral stabilized against trunk, elbow at 90 degree and forearm pronated. The therapist resists supination of forearm and external rotation of the shoulder. Positive sign. Tendon of biceps long head will pop out of groove and pain on long head of biceps tendon. Speeds test. Biceps straight arm. Aim of the test identifies bicipital tendinitis. Patient position. Patient sitting or standing with upper limb in full extension and forearm supinated. The therapist resists shoulder flexion, may also place shoulder in 90-degree flexion and push upper limb into extension, causing eccentric contraction of biceps. Positive sign. Pain in long head of biceps tendon. Drop arm test. Aim of test identifies tear or full rupture of rotator cuff. Patient position. Patient sitting with shoulder passively abducted to 120 degree. Patient is instructed to slowly bring arm down to side. Guard patient's arm from falling in case it gives away. Positive sign. Patient unable to lower arm back down to side. Empty can test identifies tear or impingement of supraspinatus tendon or possible subscapularis nerve neuropathy. Patient position. Patient sitting with shoulder at 90 degree and no rotation. Resist shoulder abduction. Then place shoulder in empty can position, which is internal rotation and 30 degree forward horizontal adduction. The patient's thumb point down to the floor and resist abduction. Differentiate if pain present between two positions. Another test with thumb up full can is best for maximum contraction of supraspinatus and resist abduction. Positive sign. Reproduces pain and or weakness in supraspinatus tendon. Lift off test. Aim of the test identify tear or weakness of subscapularis muscle and scapula instability. Patient position. Patient stands and places the dorsum of the hand against the mid lumbar spine. Then the patient lifts his hand away from the back. If the patient is able to take the hand away from the back, the examiner should apply a load pushing the hand toward back to test the strength of the subscapularis and test how the scapula acts under dynamic loading. Positive sign. Inability to move the dorsum of the back indicates subscapularis rupture or dysfunction. Belly press test. Abdominal compression. Aim of the test identify tear or weakness of subscapularis muscle, especially if the patient can't immediately rotate the shoulder behind his back. Patient position. The examiner put his hand on patient's abdomen to feel the contraction. Patient put his hand off the tested shoulder on examiner's hand and push as hard as he can. While pushing, the patient attempt to bring elbow forward, causing greater medial shoulder rotation. Positive sign. Inability to maintain the pressure on examiner's hand while moving elbow forwards. Test for impingement. Near test. Aim of the test identify impingement of supraspinatus tendon or long head of biceps. Patient position. Patient sitting and shoulder is passively internally rotated and fully abducted. Positive sign. Reproduce symptoms of pain within shoulder region. Hawkins-Kennedy test. Aim of the test identify impingement of rotator cuff. Patient position. Patient is sitting with arm flexed at 90 degree and elbow flexed to 90 degree. The examiner then stabilizes proximal to the elbow with the outside hand and with the other holds just proximal to the patient's wrist. Then passively move the arm into internal rotation. Positive sign, pain in the subacromial space. Posterior internal impingement test. Aim of the test identifies an impingement between rotator cuff and greater tuberosity or posterior glenoid and labrum. Patient position, patient supine and move shoulder into 90 degree abduction, maximum external rotation and 15 to 20 degree horizontal adduction. Positive sign, reproduction of pain in posterior shoulder during test. Test for shoulder instability, anterior apprehension test or crank test. Aim of the test identifies past history of anterior shoulder dislocation. Patient position, patient supine with shoulder in 90 degree abduction. Slowly take shoulder into external rotation. Positive sign, patient does not allow and or does not like shoulder to move in direction to stimulate anterior dislocation. Posterior apprehension test. Aim of the test identifies past history of posterior shoulder dislocation. Patient position, patient supine with shoulder elevated 90 degree in plane of scapula with scapula stabilized by table. Place a posterior force through shoulder via force on patient's elbow while simultaneously moving shoulder into medial rotation and horizontal adduction. Positive sign, patient does not allow and or does not like shoulder to move in direction to stimulate posterior dislocation. Anterior or posterior drawer test of shoulder. Aim of the test, identify laxity or insufficiency of the anterior or posterior capsular mechanism. Patient position, patient is supine, the affected shoulder is abducted at 80 to 120 degree, 20 degree flexion and 30 degree external rotation. The examiner holds the patient's scapula's spine forward with his index and middle fingers. The thumb exerts counter pressure on the coracoid. The scapula is fixed. The examiner uses his right hand to grasp the patient's relaxed upper arm and draws it anteriorly or posteriorly with a force. Positive sign, gliding of the humerus. Click may indicate labral tear. Selkirk sign. Aim of the test identifies inferior shoulder instability or glenohumeral laxity. Patient position, patient is sitting with his arm in neutral position. The examiner pulls downward on the elbow while observing the shoulder area for a sulcus or depression lateral or inferior to the acromion. Positive sign, depression lateral or inferior to the acromion. Tests for labral tear. Clunk test. Aim of the test identifies a glenoid labrum tear. Patient position, patient supine with shoulder in full abduction. Push humeral head anterior while rotating humerus externally. Positive sign, audible clunk is heard while performing test. Slap prehension test. Aim of the test, identify slap lesion, superior labrum, anterior posterior. Patient position, patient is sitting or standing. Arm is abducted 90 degree, elbow extended and forearm pronated, thumb down. Ask the patient to horizontally adduct the arm. Repeat the movement with supination, thumb up. If pain felt in the bicipital groove in the first case, pronation, and is lessened or absent in the second case, supination, the test is considered positive for a slap lesion. Pain in bicipital groove during supination. Tests for thoracic outlet syndrome. Adson's test. Aim of the test, Identifies pathology of structures that pass through thoracic inlet. Patient position, patient sitting and find radial pulse of extremity being tested. Rotate head towards extremity being tested, then extend and externally rotate the shoulder while extending head. Positive sign, neurologic and vascular symptoms. Disappearance of pulse will be reproduced in upper limb. Costoclavicular syndrome, military brace or Eden's test. Aim of the test: identifies pathology of structures that pass through thoracic inlet. Patient position, patient sitting and find radial pulse of the extremity being tested. Move involved shoulder down and back. Positive sign, neurologic or vascular symptoms. Disappearance of pulse will be reproduced in upper limb. Right test, hyperabduction test. Aim of the test: identifies pathology of structures that pass through thoracic inlet. Patient position, patient sitting and find radial pulse of extremity being tested. Move shoulder into maximal abduction and external rotation, taking deep breath and rotating head opposite to side being tested may accentuate symptoms. Positive sign, neurologic and or vascular symptoms. Disappearance of pulse will be reproduced in upper limb. Roos elevated arm east test, elevated arm stress test. Aim of the test: identifies pathology of structures that pass through thoracic inlet. Patient position, patient standing with shoulders fully externally rotated, 90-degree abducted and slightly horizontally abducted, elbows flexed to 90-degree, and patient opens or closes hands for 3 minutes slowly. Positive sign, neurologic and or vascular symptoms. Disappearance of pulse will be reproduced in upper limb. Special tests of the elbow joint: ligament instability tests, valgus and varus stress tests. Aim of the test: identifies collateral ligament laxity or restriction. Patient position, patient is sitting or supine, entire upper limb is supported and stabilized and elbow placed in 20 to 30 degree of flexion. Valgus force placed through elbow tests ulnar collateral ligament. Varus force placed through elbow tests radial collateral ligament. Positive sign, primary finding is laxity, but pain may be noted as well. Tests for epicondylitis. Aim of the test: to identify lateral or medial epicondylitis. Lateral epicondylitis or tennis elbow, Cosen's test. Patient position, patient is sitting with elbow in 90-degree and supported. Resist wrist extension, wrist radial deviation and forearm pronation with fingers fully flexed, fist simultaneously. Medial epicondylitis, golfer's elbow test. Patient position, patient is sitting with elbow in 90-degree and supported. Passively supinate forearm, extend elbow and wrist. Positive sign, pain at lateral epicondyle for tennis elbow and at medial epicondyle for golfer's elbow. Pronator teres syndrome test. Aim of the test: identifies a median nerve entrapment within pronator teres. Patient position, patient sitting with elbow in 90-degree flexion and supported. Resist forearm pronation and elbow extension simultaneously. Positive sign, reproduces a tingling or paresthesia within median nerve distribution. Tinel's sign. Aim of the test: identifies dysfunction of ulnar nerve at olecranon. Patient position, patient is sitting, tap region where the ulnar nerve passes through cubital tunnel. Positive sign, reproduces a tingling sensation in ulnar distribution. Special tests of the wrist and hand. Finkelstein test. Aim of the test: identifies decurrence tenosynovitis, paratendonitis of the abductor pollicis longus and or extensor pollicis brevis. Patient position: patient makes fist with thumb within confines of fingers. Passively move wrist into ulnar deviation. Positive sign: reproduces pain in wrist, often painful with no pathology, so compared to uninvolved side. Bunel-Littler test. Aim the test: identifies tightness in the structures surrounding the MCP joints. Patient position: MCP joint is stabilized in slight extension while PIP joint is flexed. The MCP joint is flexed and PIP joint is flexed. Positive sign: differentiates between a tight capsule and tight intrinsic muscles. If flexion is limited in both cases, capsule is tight. If more PIP flexion with MCP flexion, then intrinsic muscles are tight. Froment's sign: positive test finding for PIP restriction. Increased PIP flexion with MCP flexion implies intrinsic restriction. No increase in PIP flexion with MCP flexion implies capsular restriction. Full PIP flexion with MCP extension is a normal negative test finding. Froment's sign: aim of the test: identifies ulnar nerve dysfunction. Patient position: patient grasps paper between first and second digits of hand. Pull paper out and look for IP flexion of thumb, which is compensation due to weakness of adductor pollicis. Positive sign: patient unable to perform test without compensating may indicate ulnar nerve dysfunction. Fallon's test. Aim of the test: identifies carpal tunnel compression of median nerve. Patient position: patient maximally flexes both wrists, holding them against each other for 1 minute. Positive sign: reproduces tingling and or paresthesia into hand following median nerve distribution. Special tests of the cervical joint. Vertebral artery test. Aim of the test: identifies the integrity of vertebrobasilar artery. Vertebrobasilar insufficiency. Patient position: patient is supine. The examiner takes the patient head and neck into extension, right and left rotation and side bending. Hold each position 10 to 30 seconds unless symptoms are evoked. Positive sign: dizziness, visual disturbances, disorientation, blurred speech, nausea, vomiting, etc. Houghton's sign. Aim of the test: differentiates vascular versus vestibular causes of dizziness or vertigo. Patient position: 2 steps to this test. Patient sitting with shoulders at 90-degree flexion and palms up. Have patient closed their eyes and remain in this position for 30 seconds. If arms lose their position, there may be a vestibular condition. Patient sitting with shoulders 90-degree flexion and palms up. Have patient close their eyes and cue patient into head and neck extension with rotation right, then left, remaining in each position for 30 seconds. If arms lose their position, the condition may be vascular in nature. Positive sign: position or movement of arms determines positive finding. Foraminal compression. Sperling's test. Aim of the test: identifies dysfunction, typically compression of cervical nerve root. Patient position: patient sitting with head side bent towards uninvolved side. Apply pressure through head straight down. Repeat with head side bent towards involved side. This test is performed in 3 stages. If symptoms are produced, don't proceed to next stage. First stage involves compression with the head in neutral, second in extension, third in extension and rotation to unaffected side, then to affected side. Positive sign: positive finding is pain and or paresthesia and dermatomal pattern for nerve root involved. Distraction test. Aim of the test indicates compression of neural structures at the intervertebral foramen or facet joint dysfunction. Patient position, patient sitting or supine. Examiner places one hand under patient's chin and other hand around the occiput and the head is passively distracted. Positive sign, positive finding is a decrease in symptoms in neck, facet condition or a decrease in upper limb pain, neurologic condition. Shoulder abduction test, Bacody's test, Bacody's sign. Aim of the test indicates compression of neural structures within intervertebral foramen. Patient position, patient sitting and asked to place one hand on top of their head, repeat with opposite hand. Positive sign, positive finding is a decrease in symptoms into upper limb. If increases, it implies increased pressure in the interscalene triangle. Upper limb tension tests, ULTT. Upper limb tension tests are equivalent to SLR tests in lumbar spine. They are tension tests designed to put stress on the neurological structures of upper limb on all tissues of upper limb. Modification of the position of shoulder, elbow, wrist and fingers places greater stress on the special nerves, nerve bias. The final movement is sometimes referred to as sensitizing test. Aim of the test, evaluation of peripheral nerve compression. Patient position, see the following picture and table. Positive sign, neurologic symptoms will be reproduced in upper extremity. Upper limb tension test showing order of joint position and nerve bias. ULTT 1, shoulder, depression and abduction 110 degree, elbow extension, forearm supination, wrist extension, fingers and thumb extension, cervical spine contralateral side flexion, nerve bias, median nerve, anterior interosseous nerve, C5, C6, C7. ULTT 2, depression and abduction of shoulder 10 degree, elbow extension, forearm supination, wrist extension, fingers and thumb extension, shoulder lateral rotation, cervical spine contralateral side flexion, nerve bias, median nerve, musculocutaneous nerve, axillary nerve. ULTT 3, shoulder depression and abduction 10 degrees, elbow extension, forearm pronation, wrist flexion and ulnar deviation, fingers and thumb flexion, shoulder medial rotation, cervical spine contralateral side flexion, nerve bias, radial nerve. ULTT 4, shoulder depression and abduction 10 degree to 90 degree, hand to ear, elbow flexion, forearm supination, wrist extension and radial deviation, fingers and thumb extension, shoulder lateral rotation, cervical spine contralateral side flexion, nerve bias, ulnar nerve, C8 and T1 nerve roots.